Ladies and gentlemen, a small leak sinks a big ship, and a big train empties a room. It's very successful. So for those of you that want to know what happens in the future, may this access, let me quickly take you through a little bit of history. How do I move the slides forward? For the sake of likelihood, if you were interested in finance and you were in the previous one, you're not here anymore, I guess that you're probably more financially inclined, i.e. the opposite is probably true. For those of you that are here are keen to actually know something about the clinical aspects. You've been through all of the artificial stuff this morning in terms of intelligence, but this then the real stuff in terms of imaging. So a quick background on where it started. We think we are clever, but I'll show you soon that we are not. 350 years ago, there's already been transfusions taking place. Then I'll quickly make it easy for you to understand how to think about getting something into a patient by virtue of the heading of classifications. Make sure that you understand ports, and I'm going to really dash through that by showing you some images, and then get to the exciting part, that is where the future of all of this lies. So, the direction. So, go back there and into the 16th century, the story starts. But the one name that you'll recall or that you'll recognize up there is a Foley's catheter that we use in urology. Now look there at the date 1654. That's 350 years plus. Now that gentleman did the first transfusion between two animals. At the time, they used a silver tube, stuck it into the one, and a bone tube stuck into the other. So 350 years ago, this was already happening. Moving on to like 60 years, 70 years, 50, 30, 20, down, right into the 1980s. This is where the new stuff happened, but this is not really new. Let's move on and now just say, well, how do you think about venous access? Well, it depends on what classification you want to use. If you want to go back to that one where we had bone and metal, you could use that as a classification. And in fact, materials, bullet number 2 over there, is a way of considering the possibility of what is it, a stainless steel thing, is it a titanium thing, is it a plastic thing. But we can also say what type is it. Is it peripheral, is it central, and that actually relates to the angle. So of a PICC line, or the acronym a CICC, or a central line, is in fact what you would be familiar with. In the ICU environment, you typically find that the IV lines go into the neck or below the clavicle. That would be a central line, but I'll also show you the opposite of a peripheral line, a so-called PICC line, is possible. So the is that when you work in a ward environment and you put up a peripheral IV line, a proverbial gel pill, that thing is only safe for an odd few days, depending of course on whether there was movement and anything that could negatively affect it. A gel pill or a very common peripheral line is not a long-term solution. It is literally count the hours, 72, perhaps 90 hours or something of the likes thereof. As you then migrate down this table that we've set up here, you'll see that you can get a device or an implant where up to, as long as the body is alive, you can still do venous access, going right down to the bottom where we've got a port that is completely implanted into the patient's body. I think an important thing for those of you that are in the hospital environment where infections is a major concern is the intensive care environment where a typical central line would be placed, and an odd few days later, now typically we talk 10 days, you know, oh darn, it's day 10, we start to see temperature spikes on the individual, we need to replace. Well, this is where you're going to be struggling with infections. Are you going to do another central line, or is this perhaps where you need to go into the future? That was a bullet, so there we go. So just a quick picture of where central lines go into, and obviously you can see, read, write, and count. So that's very simple. I'm not going to go into the acronym or magic on how to decide on all of that, but that is summarizing all of that. They're just sorry, I was too quick. There's space that we need to consider where all of these things, and particularly peripheral lines, actually play a major role in. By training, and I'm an oncologist, and this is something that we would typically use because there's repeated vascular access necessary over an extended period of time. But wearing the hats of somebody that is in the hospital, there is equally so a place in this because you do not want to every single day or every third day put up a new peripheral line. And those of you that have worked in wards, when you've seen a patient that has got an edematous arm after the drip going into the tissue, and then later taking granny's leg and then strapping it to the bedside because this is the only place where you can find a vein, it's really not very human. There are better ways of dealing with the situation. So ports. Ports, we need to go back into where it started. But the thing is, we want to create a easy point where the needle can get into. That's the essence of what a port is, where it's not trying to poke into a tiny little vein that you can't see. And for that, well, you need to understand how you need to get it in there, you need to understand the materials, etc., etc. I'm going to show you a few pictures, but I think the important thing in terms of insertion is that it needs to get into the central part. And the tip of that catheter is in a major vessel inside in the chest area. So this is a sterile procedure. It's a theatre case, lovely if you're in the hospital because this is business. A patient goes into the hospital, it's going to be typically an hour and a half for the procedure to take place, but you need a skilled surgeon. This is not something you can ask me to do, it will be a major catastrophe, you'll read the newspapers. So you need somebody to be able to do this procedure. It's difficult, it's expensive, but then you've created a long-term solution. So the right patient needs this, but not all patients. There's a nice picture of what you can see. The patient feels what I describe like a button. You know, if you take the button of your shirt or a jacket and you have it under your skin, that's what you would feel. And essentially, if you flip it around, it's like a funnel when you have to put oil into the container and you decant it through the funnel into the bottle again. Otherwise, you make a mess. The top end is big, the bottom end becomes smaller, so that which is flat underneath the skin is slightly big and it becomes wide, narrower and narrower to the bottom, connecting to the tube to take any fluid you input through there close to where the heart is. So there we've got a port. You can get ports that has got the ability to take two different needles, but that's just for the fun of it. So the functioning of the port, and that gentleman there on the side has got a port that you can easily see is actually slightly underweight. You can see all the vessels very, very prominent, but there's the port in that guy's chest. The important thing is that once you've had that installed, now it's there, you need to use it over time, but is it really working? And I'm going to show you very, very, very briefly some of the errors where things go wrong, and ports aren't that easy. So, routine use is now also significantly more complex. When you're in the emergency unit, you quickly need to just put up an IV line. I mean, you're going to grab a pair of gloves, you're going to tell somebody, or put the tourniquet on the arm, see that you can find a vein, put the IV line up, this proverbial gel gun. Here we're talking about a procedure that needs to be performed in a sterile setting. Every single time you need to thoroughly prep the area, wash your hands, and then do a sterile insertion of a specialized needle. You can't now just use a normal needle either. So the port needs to be maintained. It can get damaged over the course of time. There's another lady with a port van, and the big white thing in the circle in the middle is a particular and a specialized covering that you can put on the port when there is a needle in place. So after the needle that is at a 90-degree angle has been inserted through the diaphragm, it gets stuck into place with a clear transparent dressing such as this. And the nice thing is with this, they can go home. In the environment of chemotherapy, we actually send them home typically for a 48-hour period with something that looks like a balloon or a handbag that you have on your shoulder, and over the course of the next 48 hours it slowly deflates and puts the medicine, in this case chemotherapy, into the body. So a port is a very useful entity in the correct setting. Important that it also has its limitations. You can't now, when you need to actually have a CT scan and assess the response of the therapy, inject something at pressure through that. You will will break the port. There are odd exceptions. So a port, unfortunately, is something that can have lots of complications. To just contextualize this, we started in history, we've moved through, and we're now currently in ports. We're not yet where the heading of the talk is, the future. So bear with me, I want to quickly show you what are the things that can go wrong. There is a very good, and there will always be a place for ports. So don't misjudge this in future, and I'm not trying to shoot down the concept of central ports. There is a major and an important place for them. But as you can see, things can go wrong. They can clot, they can bleed. In fact, they can even fracture. I mean, it's just a device that was made by humans. Well, in fact, in a machine. So very quickly, some images so that you can understand them. In this X-ray, you can faintly see the tube coming down there. It's not an ideal thing to just take an X-ray. You want to do more fancy things like this, and I'm going to show you now that in one of these, there will be a picture that will be live and show you where the, there's one with, let's just get to the picture. I'm trying to be brief for your benefit. The videos actually seem to not be playing. Okay, so the videos doesn't play. But the principle that needs to happen here is that before you start injecting medicine of whatever nature through a port, you want to be sure that it is in the right place. So there's something called a portogram. In this static one, you can at least see that it is injected in there, that you need to be sure that the tip of the port is in the right place. So never mind all of those complications, let's proceed through all of this. So the null positioning, I mean, there you can see, I mean, the contrast medium going into this patient's neck. If this is now chemotherapy, I mean, it's a disaster with tissue damage that will ensue in the subsequent days. Ports can get fractured. So where do we want to go to if we want to go into the future? I think for your benefit, you need to first understand that patients do not like what happens to them in a hospital. We, the healthcare solution to society, is a grudge purchase. Perhaps it's the exception of a little bit of cosmetic surgery, nip and tuck here, but by and large they don't like you. They prefer to not ever have contact with you, and least of all an oncologist. They prefer to not have you. But there's a very interesting publication by this lady that did it for her doctorate in 2020, pinholes in my body, pinholes in my arm. And where she spoke with patients that repeatedly had to have intravenous access, that were poked and poked and poked. What did people tell them? What was their experience? 4 things. They sometimes felt like they were being under attack. Now, if you are lying there and 1, 2, 3, 4, I mean, every single time there's a needle going into your arm and then say, sorry, small injection, and it's not there. Some did tell the story that they felt like they're being rescued, but others felt that, okay, well, yes, perhaps I'm being protected because then all of these other bad things is not going to be happening. But I think a very important story for us in the healthcare, particularly the hospital industry, is that how many times as a ward manager, as a hospital manager, as a matron, have you been confronted with family and or the patient that is absolutely frustrated with your incompetent staff? It's not necessarily the staff, it could be the bad veins, it could be the bad staff as well. But the reality is that the patient is the one that experiences this. And this doctrine of this lady led to the fact, or to the saying that venous access could be a nightmare. Now, is there a way that as a healthcare provider you can manage the process and avoid the nightmare? And the short answer is yes. So let me show you what the short answer is. Well, if you dream not the nightmare, but you dream the solution, is how would you do this? You would, in fact, well, dream that you can see what you want to do. Instead of just poking until you have blood pushing back. What if you can see this? If you can dream that you can do it the right time, the first time, and you can actually, even if you want to anesthetize that with a little bit of ointment before, but then put the drip up, end of story, nobody cries, not you, not the patient, and it's right there. You can dream about a solution. And in fact, that is what I think PICC lines in this setting has to offer. So a PICC line, note that same as we had in the past, it goes right to where it must be in a major vessel. But what is the entry point? The entry point is now peripheral. So the brachial vein in the arm, on the inside of the arm, is nice and big, and it simply gets inserted into that, and then still thread up into the right spot. But the difference is this: you don't go poking like in the ER unit on the arm. Let's try it around now, sir, man, let me try the other arm. No, you visualize it under ultrasound, you measure the diameter of the vessel, and you to select, and with the needle going into the right spot, there's the ultrasound device, so that you can assess where you want to place this device, and then first time right, install it. Okay. So there, just quickly, the new device now inside the lumen of the vessel. Obviously, if you're going to install anything into a vein is not an artery, there's not pressure that goes through that with a heart beating, so blood flows relatively slow back to the heart. It can easily clot if there is something furthermore obstructing the flow of blood through that. So it's very important that when you place a PICC line, you measure the diameter of the vein and not block the complete vein with a big fat Foley's catheter. You're now going to use a venous catheter that is the right French size relative to where you want to be. And that's where the future is. We don't just guess, we measure, and then we do. So, sorry, I wanted to quickly show you that. So, here's a quick few pictures of people with a port in place. You can see over there the port in the inside part of the arm, and it remains there. And go back to the table that I showed you where the gelco is for 3 days, and the port is for as long as the patient lives. Here you now have the ability to put in a device that can stay up to typically 6 months. So, and you'll soon see what the options are of where we can then use this in the clinical setting. Rather fashionably so, you can get off Amazon or Takealot sleeves that you just put over your port. Remember, underneath that, there will be those daily bits that you see over there. So the patient can be going about their social activities and have that under a cuff, neatly stored, and tomorrow or next week when they're back at their center where they need to have their second round of treatment, that can happen. Now obviously in the hospital setting, this is not what we're looking at, but in the hospital setting, the patient that is in ICU and already had a central line with or without complications, but now on day 10 needs another one. Will it not be nice in the future if there's an alternative? So you can see that there's even another future option that we can insert and then embed below the skin something called a PICC port, so a peripheral port and not a central port. There's the picture indicating the little lump below the skin of the inside of the arm. So, in closure, I think it is possible. We can have, contrary to the nightmare, less pain, less infection, less complications. We can get more treatment in all at the same time, where right at the end, not only the patient, but everybody in the team wins. The healthcare worker, the hospital, the patient, everybody can win. In the future, venous access has got numerous more possibilities.